sort of the Italian sort of audience that we're involved with. So this was work largely done at Warwick, because sort of within my group, but also sort of really benefiting from everything that Juniper had to offer. And I'll tell you a little bit more about Juniper in a moment, given this is a sort of joint seminar. Just to give you a bit of an outline of the talk, I'm going to start off with sort of the acknowledgements at the beginning. This was very much a team effort, so I like to put that up front rather than putting it right at the end. I'll talk a little bit about how we developed the model before moving on to think about 4 or 5 different examples of how the model was used in different contexts, what the outcomes were, and thinking really about it in a sort of public health sense. And each one of these little subsections, I'm going to sort of have a sort of a bit of a discussion and conclusion at the end of each one to talk about sort of how I think it went and what we could do to improve things. So the team, as I said, we had a large number of incredibly talented people working with us. These are the team at Warwick. I'm not going to introduce everybody, but, you know, large numbers of people doing fantastic work and giving an awful lot of their time. We were also working with a group of talented researchers in Kenya. So while we were doing work in the UK, we were also sort of using that to parallel what was going on in Kenya. And actually, that was really interesting to think about the similarities and the differences between the two. We were also part of Juniper. So Juniper was sort of formed in the heat of battle, if you like. So myself and Julia Gogg are the co-leads, together with researchers. So Julia's at Cambridge. So there's researchers from Cambridge, Bristol, I'm going to get this wrong, Oxford, Manchester, Lancaster, and one other, Exeter. Yes, I knew I'd get there eventually. So it was basically a large group of talented academics from around the country that were all pulling in the same direction to try and give advice to SPI-MO. So SPI-MO, and these were the sort of the main characters in a way in SPI-MO, Graham Medley and Angela McLean, who were the chairs, and then the secretariat as well, who did absolutely amazing work. But they would request information from us, and by next week, can you tell us what you think ours are going to do and what you think the impact of the football or vaccination or whatever is going to be? So we would try and then coordinate this across the different 7 universities to so that we could address the challenge in a way that was comprehensive without too much overlap between the different groups. And this was funded by MRC and UKRI. And I think the advantage of Juniper, especially when we're thinking about COVID, is just the depth and the speed of science that we could produce. So we put into the R estimates throughout the pandemic. We did a lot of work on new variants, but we also did sort of communication, both of sort of rapid papers to SPI-M, but also through the Plus network of science writers to try and sort of output what we were doing to an educated but not sort of mathematical audience. And really, I think, almost the bottom of these bullet points is the main one, that humans work better together. We were a very supportive and interactive community that allowed us to really pitch our results and do the maximum that we could. So, we most of it was done online, most of it was done through emojis, but, we were in the situation of being able to sort of just share things and share our experiences. So that was during COVID. We also did lots of things, on understanding and influencing policy. So we've got, as I said, we've got Plus articles, we've got hundreds of different reports, hundreds of different SPI-M meetings, lots of PDRAs, lots of work that went on in a vast number of different areas. So almost anything you can think of that happened during COVID, there was probably someone on Juniper that was involved with that. But sort of moving forward, we're now in what's called the Juniper Partnership. So we're thinking more long term. We're thinking about building an inter-university community of epidemiological modelers all working together. And really, it's people working at this interface between infectious disease modeling and public health policy. We're also there to provide support and training for future leaders. This isn't just about sort of taking the people who've already made it and are already sort of excel, but it's picking, it's training the next generation. It's been fantastic to see people like Francesca who've come through the system, were postdocs as part of the original Juniper, but have now moved on to sort of, starting to have leadership roles in their own right. And we're also thinking about it being outward facing to the sort of wider research community. And part of this is some of the excellent staff we've got. So Kira Dangerfield, who has come through sort of Warwick and then UKHSA and is now in Cambridge, who's our scientific program manager, and really drives forward what Juniper does. We have Marianne and Rachel, who are our science writers from PLUS, and really help us communicate what we're doing. And then we've got Alison Hale, who's just started with us, who's a software engineer, who's helping to take the next generation and train them into how to develop good software. Okay, so that was my introduction to Juniper, a bit longer than I expected, but I'm now going to go back to thinking about COVID and the development of the model. So this all started with sort of wave one and the very early dynamics. And we realized that we needed a model that could capture the timeframes of infection. It's also, which we did as a sort of, we started with an SEIR model and went, well, actually, we need multiple E classes to give us an Erlang distribution, which tends to get the time frame better. We needed to split the infectious class into symptomatic individuals and asymptomatic individuals. These are asymptomatic individuals, which we label A, have a lower infectiousness, so they don't transmit as much as those that are fully symptomatic, because fully symptomatic people are sort of coughing more. So we put that in from the early stages and seems to have been borne out in a lot of the more detailed sort of household level studies. And then those that were fully symptomatic could go on to have severe outcomes. Generally, this was a factor of age as to whether or not they got hospitalized, whether or not they needed ICU treatment, and whether or not they may unfortunately die from the pandemic. And then all of those went on to a recovered state, which worked very, very well for the first wave. We were able to look at things like lockdown. So we actually had a sort of, there's frameworks underneath this that allow us to look at sort of household isolation in more detail and think about who infects whom within that context. The model needs to be age structured. So we haven't just got sort of one set of this, we've got a whole other set, 21 classes that captures 5-year age bins. We also capture the spatial structure slightly within the UK in that we look at the 7 devolved nations, so big areas like the Midlands or London, as well as the devolved nations. So we've got a model that runs for Scotland and one that runs for Wales. Those aren't coupled, and that was decided upon quite early. Firstly, it simplifies the modelling tremendously, but also there wasn't that much movement, certainly during the first wave. And so actually the interactions between these spatial units didn't seem to be that important. One of the things there's multiple things that drive what's happening. Really, all of this can be captured in terms of R, the reproductive ratio, and part of our job on SPI-M was to model or infer what R was each week. But several things could lead to increasing R. Waning immunity, which we ignored early on, as with variants, we didn't sort of know about those. But certainly sort of greater social mixing would lead to increases in R. And then decreases, well, things like testing, compliance with the isolation measures, use of masks or reduced mixing in some way, and then a bit later on, vaccine efficacy and vaccine uptake would all act to reduce R. So we've got these multiple components, and some of these we just couldn't get to. In particular, the levels of social mixing, things like mask use, testing and isolation, we combined in a single inferred parameter, which we talk about as precautionary behavior. And this precautionary behavior, which you can see here as the black line, and our confidence intervals around it are in gray, actually compares pretty well to some of the sort of mobility data that's out there. So the red, blue, and green lines are from the Google mobility data. So very detailed data taken on sort of, what people are actually doing and how they're moving around and tracking them in real time. And, we're getting a very, very good correspondence between our inferred behavior and the movement behavior, noting that this movement behavior won't take into account things like hand washing or mask use, which will sort of tend to sort of should be reflected in our estimates, but won't be reflected in Google. So when we did this work and we were doing our sort of early dynamics, even back in sort of April and May of 2020, our main concern then was how we were going to relax on the lockdown. So we knew that there was a massive pool of susceptible individuals still out there, and we really wanted to consider what would happen with different levels of control or non-control as we went through. So we thought about different levels of relaxation and then switching off control at the end of 2020, because back then we thought the epidemic might be over by the end of 2020. But even when we did this, the best we could ever get out was an epidemic that led to about 150,000 deaths in the UK. We're over that now, but not too much over it. But before we sort of start congratulating ourselves and tell us how well we've done by getting an estimate that was, pretty close. This was before vaccination, so none of our models back then had the impact of vaccination, but none of the models had the impact of variants either. So both of these are going to be themes of what I'm going to talk about, and really just disrupted the entire picture. So I'm going to start by talking about the second wave and the November 2020 lockdown. So in the UK, we had our first wave, which peaked in late March, early April. Cases declined until June, July, and then started to rise again. And it was very clear by sort of August, September that something needed to be done. And there was a lot of push from the scientific community that we needed another short lockdown. So there was this big concern over increasing number of cases, and it wasn't quite clear what to do. The first lockdown had seemed to be incredibly expensive in terms of disruption to the economy, disruption to schooling, all sorts of sort of social complications. And so the idea was proposed that we'd have a short-term circuit break. And I think the key to this was that it was short-term, so it had a finite duration. And so we knew that, we could do it for 3 weeks, 4 weeks, or, well, somewhere between 2 and 4 weeks was the initial proposal. And with the idea that because it was finite, people would be able to cope a lot better, as would businesses. And when we looked at this, I mean, the mathematics behind it is actually very, very simple. We're in a situation of exponential growth without the lockdown. We put a short-term lockdown in and we go into exponential decay. We stop the lockdown and we go back to exponential growth again. But what this is doing, and it's easier to see in some ways from a logarithmic scale, is that this lockdown effectively just takes us backwards in time. It gives us this sort of reset, which, although in the long term isn't a solution, it allows us to actually think about putting other control measures in place, such as vaccination, which we knew was somewhere around the corner. Oh, which is what I've just said and all about. So those results were from really simple sort of toy models of just pure exponential growth and pure exponential decay. We can put all that into the full model. So this is age structured, much more complicated behavior, and actually look at what happens for different types of circuit break, depending on how rapidly it halves the number of infections. Here we're just looking at numbers of cases in London, but we could do this for all the different regions. And what we see is effectively the same sort of pattern. Each of these circuit breaks takes us back in time and gives us more chance to actually put other measures in place. So, yeah, if we go through the full age-structured models, we see a similar sort of pattern. We can look at sort of how it would impact total infections over the period from when we're thinking about the lockdowns coming in sort of October. The idea was going to be to try and time it with the October half term to disrupt, to minimize the disruption on schools. So schools were already closed. You wouldn't have that much of an extra burden by closing, some of the sort of retail shops and other things. So we could look at different levels of control based on hospitalizations and infections, depending on what the growth rate was and depending on sort of how much control we could get through the circuit break. It's quite clear that breaks are only ever a temporary measure. They're just putting delays into this exponential phase. But what they can do is they can reduce the scale of the overshoot. So we know that from all classic epidemic theory, you always get an overshoot so that more people become infected from an epidemic wave than you'd expect at an endemic equilibrium. And so by putting in breaks, you can actually reduce that effect quite significantly. And we were looking at examples here where we could sort of drop, in the worst case, we were dropping sort of hospitalizations from nearly 300,000 down to 150,000. So we were halving hospitalizations over the period we were thinking about because we were putting this break in. What actually happened? Well, the 4-week break did come in a bit longer than we expected and a bit more delayed than we expected, but it came in throughout November. And what is clear is that there's a significant decline in hospitalizations after the break comes in. So, it's definitely doing its job. It's definitely working well. There's one exception to this, which is the light blue line that you can probably see here, which is just steadily increasing all the way through the break. And what we thought at the time was, oh my God, what are these people in the Southeast doing? Why aren't they obeying the lockdown? We were wagging our fingers and shaking our heads at them without actually realizing that what we were seeing was the emergence of the alpha variant. But at any rate, what we can see is that in general, these circuit breaks are incredibly effective at trying to control an outbreak when there's no other pharmaceutical measures available. So my sort of conclusion to the circuit break a bit is that these short-term fixed duration lockdowns can be used to mitigate a rising epidemic. They don't just work on COVID, they could be used for other things. So, they're now a sort of one of our sort of tools that can be deployed. We think they're probably less harmful than other non-pharmaceutical interventions that might have an indefinite duration. The fact that people can plan for a 3-week or a 4-week lockdown is probably a good thing. They're definitely not long-term solutions. We can't just have one circuit break and think, well, that's going to have done everything. That's going to sort of eradicate our problem. But they do buy us extra time. And hopefully we can use that extra time to better prepare or to introduce other measures such as vaccination. And vaccination was coming along at the end of 2020. I'm going to come back to this circuit break idea when I talk about economics, but that's just a primer to give you an example of what actually happened in November of 2020. So I now want to come on to the other thing that happened in sort of wave 2, which was vaccination. So to implement vaccines, we needed to put in an extra copy, at least, of the dynamics. What we were really doing when we did it properly was we put in 2 copies, because we realized that we had to do 2 doses of vaccination. So we had to have individuals that had 1 dose and were partially protected, and individuals that had 2. But when we started this work in October, so before the circuit break, this was before any of the phase 2 and phase 3 data had actually been published. So we were really working on very, very limited information. We started by thinking about 3 different types of vaccines. Ones that reduce susceptibility to infection, which is what happened in the real world, and therefore could block transmission. Our second type was to reduce symptomatic disease, which would probably also reduce transmission, because asymptomatic individuals were thought to transmit less. And then our third type was vaccines that just reduce severe disease, so would stop hospitalizations and mortality, but wouldn't have any impact on transmission. The actual vaccine was a mixture of all 3. So it reduced susceptibility, depending on the vaccine that we were looking at, somewhere between 65 and 80%. It reduced transmission, because it made less people have disease. That was somewhere between 80 and 90%. And certainly it had a massive impact on severe disease. So it really did reduce hospitalizations, and the reduction there was well over 90%. But what we found from this early work, and is illustrated in all these bottom graphs, is that by far the best thing to do as you start rolling out the vaccine is to give it to the older individuals first, probably to starting with those that are over 80, then factoring in individuals that have comorbidities of all age groups, and then moving on to your over 60s, over 40s, and so on. So we moved down in an age-structured way. And that was consistent for whatever level of, whatever the growth rate was at that time, whatever the efficacy of the vaccine, and whichever type of vaccine we had. It really didn't change this pattern very much. And here we can see either doing age or doing age and comorbidities, compared to the blue line, which is just vaccinating at random. So by now we'd realized that there was this alpha variant, and we'd also got vaccination going. So we'd now got 6 copies of the model, because we'd got a wild type and an alpha, and we'd got 2 different doses. So already you can see the complexity of our model is building up, or at least maybe just the number of different compartments. I mean, it's just a sort of multiplicative thing on the complexity. So we were having to infer a lot more parameters, although fortunately, Public Health England, who are now UKHSA, were doing a lot of the estimation of the vaccine efficacy and vaccine level protection. So that was incredibly useful, that got filled in. What the sort of latter work showed was that, we knew we'd got this massive wave that was increasing. So the lockdown had helped to reduce some of that burden, but we were in the middle of our second wave. It was being fueled by alpha, and the assumption was, oh well, we've started vaccinating, we can just shut down our controls, we can just shut down all our non-pharmaceutical interventions. Well, this graph really shows what happens as you do that, which is, even if we just let our non-pharmaceutical interventions roll on from January to April, which was longer than a lot of people actually wanted, if you suddenly stopped all interventions, you would get an absolutely massive outbreak. So even after 3 or 4 months of vaccination and around 30 million doses, a sudden halt was actually catastrophic. And really what you have to do is have a slow relaxation of controls over a long time period. And it's only that really allows you to stop having a major outbreak as soon as you sort of halt your control measures. So really the message here was go slow and go steady. And this led to an awful lot of work during 2001 on things called the roadmaps for relaxation, which looked at how we relaxed our control measures gradually to prevent having sort of subsequent large-scale waves of infection. The other question that we looked at, so we've talked about sort of age priority, but the other question, and probably this is where the UK differs from a lot of other countries is thinking about the timing of the 2 doses. So the guidelines, certainly for the mRNA vaccines, was that they should be given 3 weeks apart. Now, the problem with giving them relatively close is that you end up in a situation where you're giving 2 doses to all your very vulnerable individuals and leaving a large proportion of the population still susceptible. So I can remember one of the advisors at the time sort of characterized this and said, well, you know, if you've got 2 doses of vaccine, do you give 1 to your granny and 1 to your granddad, or do you give 2 of them to your granny? And obviously the answer to this is you give 1 to each and then wait till your next vaccine and then give them both. So it really is this question of how we do the prioritization. And myself and Ed Hill looked at this with some relatively simple models, thinking about what dose 1 does versus dose 2. So if 1 dose is only gives 70% of the protection that dose 2 does, then you want a pattern that looks like this top graph, where you start off giving it to healthcare workers, and then you give healthcare workers their second dose. You then move on to group 2, which is the over 80s. You then do group 3, which is all the 75 to 79-year-olds, before going back and giving your second dose of vaccine to the over 80s. And so we have this pattern of who you're giving first and second doses to in such a way that you manage to get some level of protection to the majority of the population. If the efficacy for dose 1 is much more comparable to the efficacy of dose 2, sort of sitting at about 90%, then actually you're much better giving lots and lots of people their first dose and then reverting back and giving second doses. So it very much stretches this picture. We're probably closer to this 70-dose regime. We didn't go for something as complicated as this and mixing the intervals up. But what we did do is we stretched that timing between first and second dose from 3 weeks to 12 weeks. So we've since looked at this. Well, both the questions. So first was the sort of, who do you give the vaccine to? And the other one was this dose interval. So the work here shows what happens. We fit our model, so the blue dots are our data on deaths. We fit our model to that data, and this uses the known pattern of vaccination. It does what we did in the UK, which is eldest first and vulnerable first, working down to younger and younger age groups, and giving the vaccine at a 12-week dose interval, so that we were getting some protection into the majority of the population. We can then start doing counterfactuals. We can change the pattern of vaccination, but although we're changing the pattern of vaccination, we're keeping the number of doses given each day the same, and we're keeping the uptake in each age group the same. So no one's losing out. It's just changing the order in which people are vaccinated. So the first line to look at is the green line, which is we reverse the order of vaccination. So instead of giving it to the eldest first, we gave it to the youngest first. So this type of approach, not exactly youngest first, but this type of idea of giving it to those individuals who are mixing the most and most responsible for transmission, was tried in a few countries, but the majority of people did go with the eldest first idea. But what you can see is that doing the oldest individuals first gives a much steeper decline from the peak of that first wave compared to doing youngest first. And this is really because you're protecting those individuals that have the greatest risk of mortality. Things start going slightly weird towards the end. Oh, I should say, we do this from when vaccination started in the UK, which was the 8th of December, until we started doing booster doses. Because by the time we started doing booster doses, we got waning of vaccination, and we got, what do you then do with the order? Do we change the order of boosters or whatever? It all got way too complicated. The other question that we looked at, which is shown by the red and the pink lines, are thinking about a situation where instead of dosing at 12 weeks, we dose at 3 weeks. And the pink line, oh, I've got the colors wrong there. The pink line actually shows what we think happens if you do a 3-week dose, which is actually there's a slight reduction in efficacy simply because of immunological aspects. So it looks as if you get a better immunological response for a dose at 12 weeks. So, not only does it give you sort of better protection at the population level, but it also gives you better long-term protection at the individual level. So what are the outcomes of this? Well, yeah, we've sort of reanalyzed this, and interestingly, the Imperial College has also reanalyzed almost the same graph, published at almost the same time with about the same numbers. And what they suggest is that if we'd have gone for an alternative vaccination strategy of sort of youngest first, which is the green line, and it's easier to look at the sort of cumulative deaths that we see, we'd have expected an extra 18,000 deaths if we'd have got the order wrong. Or if we'd have gone for 3 weeks, and this is 3 weeks as sort of thinking about this lower efficacy, then you're talking about an extra 15,000 deaths. And both of these in theory are additive. I haven't done a model with youngest first and at 3 weeks because that just seemed a bit of an overkill. So those are staggering numbers in their own right. But if we think about this in a sort of health economic framework, then even though most of the deaths were in older individuals, it's estimated that each death loses about 8.5 QALYs or quality adjusted life years. So we can think about that as a sort of as a scaling quantity of how much life we've lost. And then if we use the standard costing framework that happens in the UK, which is £20,000 per QALY, then we're effectively losing, or the cost to the UK is £175,000 for each COVID-19 death. So these two strategies that we put together that saved 18,000 and 15,000 lives, we're talking about 3 billion or 2.5 billion respectively, just by getting the ordering and the timing of our vaccination right. So that's really what this summary says. Rapid development of the COVID vaccine is undoubtedly the scientific triumph of the pandemic. If you'd have asked any of us at the start, how long will it take to get a vaccine, we'd have gone years. No one believed we could have done it within a year. And, hats off to all the people that were involved in that. And what we've really shown is that, thinking about vaccinating the most at risk first, thinking about this longer interval that has protective benefits, really did have a substantial impact on the epidemic. I'm now going to move on to economics, and hopefully I'm going to have a little bit of time to talk about Omicron, but we'll see. So in a similar vein, when we're thinking about COVID controls, we need to be able to balance the health impact of the pandemic, which are reduced by controls, against the economic impact of controls, which, not surprisingly, the more control we put in, the more economic impact there are. So there's a balancing act between these two. They got separated during the pandemic, so nobody ever looked at this interaction. But I think it's very important that as we move forward, we start to bring this more and more into our pandemic planning. So the obvious question that we quite often get asked by when I sort of talk about this is, why don't you just find an optimal solution? There must be an optimal solution out there. You're mathematicians, you do models. Why don't you just minimize something or maximize something? And the answer is because we don't really know what we should be maximizing. We don't have this objective function that someone wants to sort of, get as big as possible or as small as possible. And so in this work, we tried to minimize the total loss between deaths and cases and hospitalizations due to COVID against the economic impacts of lockdowns. This was our best fit, not terribly good best fit, but the best we can do at trying to look at what the monthly GDP as a measure of the sort of economy was. We see that the first lockdown or the first impact of COVID had a massive impact on the economy. And then the November lockdown had a smaller impact. So we're overestimating one and underestimating the other. And we're comparing that economic thing with what the cost is from COVID cases. So we do some quite complicated models. We run them. We initially started thinking about running them from June to January 21. It's funny, since COVID started, I've had no idea what year I'm in. So that was June 2020 to January 2021. We assume there's a baseline level of control, which is shown on the x-axis, and then we can put in two circuit breakers, two of these short-term lockdowns, if you like, that have their own level of control and their own positioning. So we run through lots of levels of control on the x-axis and lots of positions, which gives us the sort of the lines in each of the situations. And we look at the total losses due to QALYs. So this is your health loss. We look at the economic loss, and then we combine the two and find the minima. And then we can output this in terms of sort of hospital admissions or deaths and whatever, wherever we put our circuit breaks in. And in each of these, we do it at a certain willingness to pay, i.e., how much we think a QALY is worth. So one of these life years of health. And as we see, if we value them at 20,000, then we have this pattern where our optimum solution would actually be this sort of quite early introduction of a first circuit breaker, followed by a second one in September, October, to suppress the size of the hospitalization and mortality waves. And we can do this across a whole range of different amounts that we're willing to pay. Not surprisingly, the more we're willing to pay, the greater value we put to life rather than the economy, the smaller the wave of hospitalizations, and also the smaller the wave of deaths that comes out from this system. An alternative way of thinking about this, or alternative way of visualizing it, is this. So it's exactly the same data. All I'm doing now is actually showing the sort of level of control in the background. And so what you can see, for a low willingness to pay, you have low controls outside the lockdowns, slightly stronger controls during these two lockdown periods, and then weaker controls again at the end. As the willingness to pay increases, the strength of all these controls also increases. But for this situation, we're ignoring hospital capacity. So the other thing we did is we realized that hospital capacity was really important. So obviously, if you have too many people going into hospital at any one time, the quality of the service drops in such a way that it becomes sort of infeasible. You know, in some ways, you break our health system. So we were able to think about putting a cap on that. And here we've said we don't want more than 10,000 people in hospital at any one day. And again, what this is going to do is increase the level of control that we need to actually keep within that regime. So that was done in retrospect. We also sort of thought about it looking forward a bit more, and thought about what would happen as we started to relax our controls out of the January 21 lockdown. Again, we could do this for different willingness to pays, but I'm going to highlight it here for the 20,000 £20,000 per QALY, and thinking about what we'd expect your sort of optimal solution to be. And what we see is that the best that comes out of this is, again, this slow, gradual release of the lockdown controls, a bit like what was shown in the other vaccination work. So this isn't just picking one and seeing what's best. This is actually trying to find an optimum that minimizes economic and health outcomes. But you do find that you would have controls going on way out into September and beyond of 2021. So a much slower relaxation than was actually seen during the pandemic. There's a few problems with this approach, which I'll just mention quickly. The first is that the lockdown, the impact of lockdowns doesn't seem to be uniform throughout the pandemic. The first lockdown seemed to have a much bigger impact on GDP than the second or the third. we're putting a lot of this down to just the market uncertainty, and the fact that, you know, there was global panic about the first the first wave of infection, which probably hit the market much harder than just the impact of lockdown. So we're probably sort of overestimating the economic impact throughout all of this. The second thing, and this is quite often sort of mentioned by people, is we're not taking into account the social impact of the pandemic. So it didn't just impact health, it also impacted sort of people's mental health, it impacted people's livelihoods, it impacted social interactions. So these things are going to get worse as we put controls in, but they may also be worse if there's more mortality in the system. You know, questions about, you know, what's going to have the biggest impact on your mental health, a lockdown or losing a family member. You know, it's not a clear question. The other bit that also gets ignored and we ought to think about is the economic impact of the pandemic. So if you suddenly lose part of your workforce because of infection, that also must have an impact. I'm going to skip that in the interest of time. Finally, I'm just going to come on to Omicron. So we're now in a situation where our model has increased in complexity to such a state that I can't actually fit it properly on a page, and I just have to put infection in a box. And that infection captures all the different variants that are out there and how they interact with in terms of giving severe outcomes. We also need to think about multiple doses of vaccine. We need to think about waning. We need to think about boosting. There's an awful lot that went into trying to understand the Omicron outbreak. And really, we thought that Omicron should have been the test bed for models. We'd understood a large amount of what had happened. We'd seen the Alpha variant. We'd seen the Delta variant. We should be in a position to try and make detailed policy forecasts. What was clear in early December, if we started looking at genomic data or S-gene target failures from some of the testing, it suggested that Omicron was rapidly replacing Delta. It jumped from about 1% to 10% of cases in about a week. This is a vastly increasing infection. And yet, how do we translate this signal into sort of hospital admission? So we did a wealth of different forecasts, basically making different assumptions about what would happen in terms of hospitalizations when we couldn't actually see any change in hospitalizations yet. So these ranged from, as we went through the early stages, so there was both the London School and Warwick were making forecasts. London School was predicting sort of 7,000 cases of hospitalizations, sorry, 7,000 hospitalizations a day. We were predicting over 10,000. The numbers went up and down. You know, we got values here that went up to 40,000 in a worst case scenario. However, after all of this, the peak came out at around 2,000 cases on the 4th of January. So 2,000 hospitalizations on the 4th of January. So why is that? Well, I've recently done this work, and it's looking at refitting the data as we go through. So the last sort of major data update we had was on the 7th of December, just before sort of things shut down for starting for Christmas. And so we could look at what was happening in terms of observed hospitalizations, which were relatively flat. And we could look at what was happening in terms of the proportion of infection that is, the proportion of infection that's Omicron compared to Delta. And we could make a projection, and what you see is because the proportion is the thing that's driving it, we actually get a really good fit to the proportion, but a really poor fit to what's going to happen in the future. And here we're just assuming that Omicron is a fast Delta. So that seemed a reasonable assumption. We found that Alpha and Delta were slightly different to wild type, but not very different in their characteristics. So just assuming it was faster and spreading more easily seemed to be the thing to do. We can start doing this as we move forwards and repeat it at sort of 5-day intervals. And what we find is that, well, really, we just cannot get a good fit to the data by assuming it's fast Delta. And we don't really see this discrepancy come in until late December. So it wasn't almost until we were at or getting close to the peak that we could really tell that a fast delta assumption wasn't appropriate. So we can rerun our models, allowing the Omicron parameters to vary. And what we find is that we can get a much better fit. But again, it still takes us into January before we're actually capturing the main differences and capturing the peak. So actually, the fact that our initial estimates weren't perfect isn't too surprising, because it just seems to be incredibly hard to capture an outbreak when all you've got is a limited amount of data. And very often you can't capture the peak until you're there. So just in conclusion to that, so, I think predicting the peak from early outbreak data is incredibly uncertain. It's a major sort of problem sort of going forwards. We only really got an improvement in our Omicron wave projections by shortening the generation time, which, if you just shorten the generation time, that would increase the rate of takeover. But actually, you then scale it back because you have to fit to the data. We reduced the severity, and probably the most important thing was there was a change in behavior in terms of less mixing over Christmas than we expected, and also more testing. And I'm just going to finish off and say sort of a few sort of lessons learned. So, I think my lessons for future pandemics are: develop a very thick skin. Models are sort of just projections of what might happen. They're definitely not forecasts, but they are going to be scrutinized, and they're going to be compared to the unfolding epidemic, and they are almost certainly going to get criticized. I think the second thing I'd say is that you just can't predict human behavior. The Euros football championship had a massive impact on the wave in England. I think we got through to the semi-final. And people have said, well, it's obvious it's going to have an impact. Well, it is, but we couldn't forecast quite how long we were going to remain in the competition. The pandemic, when people started using the mobile phones more to sort of identify things, had an impact. And there also seemed to be a response to things that came from our chief medical officer in 2021, talking about how we ought to sort of try and protect each other from Omicron. All of these was sort of certainly unpredictable, if not unexpected. Models are always going to be wrong, but they should be useful. And very often the departure of the data as it comes in from the models can hint at changes of underlying behavior. I think that's one of the areas in which the models are incredibly useful. Data is key. So models are never any good without data. We still don't use genomic and immunological data as much as we could. It tends to be a little bit, or certainly the genomic data tends to be slower than the epidemiological data, but that sort of individual level data should be extremely useful, but it's ethically challenging to use. And so we need to think about how to incorporate that. I'd also like to sort of really sort of raise a flag for sort of a holistic approach. So we shouldn't just be thinking about health. We really ought to be thinking about all aspects of health, wealth, and well-being. It's often very difficult to put all these in the same framework, but that doesn't mean we shouldn't try. And then I think the last thing is teamwork is vital. So in the UK, we were really, really lucky to have SPIAMO, which integrated projections from the whole of the sort of UK modelling community, and meant that we had a shared responsibility. So it wasn't the Warwick model going out there on its own saying things. It was a set of aggregated model results. I also think I've been really lucky to be part of the Juniper Consortium and the large team at Warwick that's worked with me to try and sort of support and help throughout what was a sort of quite traumatic 2 to 3 years. Thank you.
Thank you. Thank you, Matt. It was an amazing, you covered amazingly a whole amount of work, of years of work. So let me stop the recording and maybe